Welcome to the Fed to Fed Podcast's MHS Digital Front Door series. In this special collaboration with the Leidos Partnership for Defense Health, we explore what it takes to drive digital transformation in government healthcare. Through candid interviews and virtual panel discussions, we're driving thought leadership on tech innovation and government healthcare. We are so happy to have you tuning in.
Hi, my name is Mary Womack. I am the MHS Health Strategy Director here with the DIMSUM program. We are the global deployment of the Genesis electronic health record for the military health system. With us today, we have Mr. Terry Dover, who is the product owner and product manager for the digital health toolset on the DIMSUM program. We also have Mr. Mitch Mitchell with us, who leads government affairs for the Amwell tool that we are implementing under My Military Health. And last but not least, we have Mr. Josh Lordemann, who is the chief engineer for digital health for the DIMSUM program. As we get started, I will be asking a few questions, a little follow-on. Before we dive in, though, Terry, would you like to pull the thread a bit and expand on what I did with my introduction there?
No, thank you for that. And as you mentioned, I'm the digital health product manager here at the DIMSUM program office. I think more importantly, I'm a consumer. The thing that I'll add the most, I was born into the MHS. I'm a military brat. I served in the military, retired from the military. My wife retired from the military. And of course, our kids have been a part of that system as well. So the most important thing for me here is not just being the product manager and serving our beneficiaries, but really just being a consumer, literally from day one. Sometimes I jokingly say I'm only a few years old because I feel like I never really left the MHS.
All right, thank you, Terry. And over to you, Mitch.
Thanks, Mary. Thanks for having us today. As Mary said, my name is Mitch Mitchell. I lead government and public sector growth for Amwell. I've had the privilege of working with the military health system for a number of years, not just in this role. In that experience, I've really come to appreciate the opportunities to help improve the way in which our service members and their families have access to care and help drive the primary readiness mission for our military. It's great to be working in a partnership like we are here with LPDH and DHA and the DIMSUM team to really drive transformative change.
Thank you, Mitch. And last but not least, over to you, Josh.
Thanks, Mary. In the 20 years that I've been with Leidos, my time supporting DHA and the partnership has been probably the most rewarding. My teams have delivered on multiple digital health capabilities, and so looking forward to continuing that support. Thanks.
All right, Terry, we'll start off with you. Can you speak in broad brush strokes about the MHS care mission today and key drivers that are affecting this modernization and change?
Thank you for that, Mary. So as most of our audience knows, the DoD completed the deployment of MHS Genesis earlier this year. It's now live and operable at all of our fixed facility hospitals and clinics, roughly about 3,800 locations. That includes some VA, the Coast Guard, and of course our NOAA sites. As I mentioned with the VA, we recently completed the deployment up in North Chicago at the James A. Lovell Federal Health Center. And so that's our first synchronous deployment with the VA, which is a really big step, showing that our affirmation there of working together with the VA and deploying a federal EHR. And now with our deployment complete, what's most important is we now really start working on optimizing the patient and provider experience and maximizing what we can do with the data that the EHR provides to give us the best healthcare outcomes. What I'll say about that is that falls directly in line with what the MHS is trying to do with General Crossland's initiative to increase accessibility and the flexibility of healthcare and bring healthcare to our service members whenever and wherever they need it, or as we like to say, meet them where they are. That's a big foundation for for DHA's Digital Front Door. It's now actually called Digital Front Door Plus initiative, which includes Digital First. And of course, we're a big part of that.
All right, thank you so much, Terry. And Mitch, on to you with your long history and many years of working in this space. Can you pull the thread on that just a bit for me and kind of talk about how the tools that we are bringing in as a thought leader in this space that can truly address the challenges that we're facing, as well as any potential opportunities that may exist as we move forward?
Thanks for the question, Mary. From our perspective, and I'll speak really from the team's perspective, as I mentioned previously, I've had the opportunity to work closely with MHS through a number of transformative efforts, including going back, to 2016 as the primary care model was shifting to become more of a team-based medical home-centric model. I think this is an evolution of that change. I think the introduction of technology really supports a broader transformation of the military health system to become more patient-centric. And I think the tools are really going to help improve access, really reattract that care back into the direct care system, and give beneficiaries the ability to interact with their healthcare delivery in ways that they've never really had an opportunity to do so before. In part, it's because of where we are just in time. I think technology has evolved considerably over time. The tools we have today and the accessibility of those tools that we have today didn't exist 5 and 10 years ago, or they didn't exist in their current form. They've evolved considerably. I think we've created lower friction mechanisms by which patients can engage with their care teams through things like automation. I think AI is going to become an increasingly more important ingredient, although I think moving in that direction cautiously is advisable, because you're never going to want to sort of diminish or discount the relationship that a patient or a beneficiary is going to have with their healthcare provider, their primary care manager, or a member of the care team, or more broadly, the health system, in this case, the military health system, seeking to establish that relationship, that long-term relationship with the beneficiary population. Terry's a great example of that. And he's been, he was born into the military health system, and now he continues to support that. That is a long-term relationship. And I think as we continue to evolve opportunities to engage with beneficiaries more effectively, connect care teams more seamlessly and in a low friction way, we'll be able to drive better outcomes and better experiences for patients going forward.
All right, thank you so much, Mitch, for that insight. Now, Josh, over to you as an engineer and a technologist, as someone that has led the product line for the DHMSM virtual health tools for several years now. What processes and what tools are you bringing to bear to bring this solution into the ecosystem that are truly making this a patient-centric platform?
Yeah, really, the pandemic really started to drive things and accelerate the need to deliver care when and where it's needed. Prior to that point, an in-person visit was, kind of the typical thing. And the pandemic certainly drove demand for virtual healthcare tools, allowing both the patient and the care teams to engage and drive and drive support for particularly the beneficiaries in this case. The challenges with the MHS ecosystem, certainly are significant. Being a worldwide healthcare ecosystem has certainly presented challenges from a technology perspective, and forced us to really think about innovative new ways to apply technology and deliver care to the beneficiaries. Thanks, Mary.
Thank you so much for that, Josh. Mitch, as we think about this and as we look at the digital modernization that these tool sets are supporting, driven by General Crossland's vision, a lot in the news has been written lately about DHA outsourcing into the purchased care environment, about how more than 50% of our facilities are based on what are called healthcare deserts. Can you pull the thread a little bit on that for us and discuss some of these concepts?
Yeah, thanks, Mary. So drafting a little bit off something that Josh just mentioned. The pandemic really changed the game, I think, for digital health, not just telemedicine, but it really opened the eyes for many to the power of the technology helping to improve access to care in remote and rural communities, especially. The TRICARE program, I would characterize the TRICARE program as being a very successful mechanism to improve beneficiary access to care broadly across the global enterprise. Um, the the needs of beneficiaries in areas where there may not be a military treatment facility or a clinic to be able to access care is really dependent upon, the TRICARE managed care support contractors building those networks and providing that access. Now, I think as an extension of that, the technology, the My Military Health and the Digital Front Door Plus initiatives are really going to break down a lot of the geographic barriers. And I think the benefits of that are going to accrue to the Defense Health Agency and to the managed care support contractors in the TRICARE program in ways that I think we will continue to be surprised at the impact it will have. And what I mean by that is I think it will help the military health system and the direct care components of the military health system more effectively optimize their resources across their global enterprise. The ability to project clinical resources into communities that may not have those resources available to them in a brick and mortar way, those barriers are going to get broken down. I think greater collaboration with the managed care support contractor partners is going to be an outcome of the technology as well. Technology like we are discussing today is fairly well deployed broadly across commercial healthcare systems around the country, and it's those healthcare systems that the managed care support contractors rely on in the development of those networks. So I think the way the team is architecting these solutions using commercially available products and using standards-based approaches for interoperability are going to create the opportunity for greater collaboration between the managed care support contractors and those that are participating with TRICARE, the direct care system, and help the Defense Health Agency more effectively project their resources across their global enterprise.
Thank you so much for that, Mitch. And now over to you, Terry. What challenges do you see and what opportunities do you believe that we have to help address these healthcare deserts with the tools that we are currently deploying?
Yeah, thank you, Mary. So, I always like to say technology should be an enabler, and Mitch really touched on that. The way I see this is we are now going to be able to bring the full bear or bring to bear our full resources across the entire federal healthcare ecosystem and our partners. And, with the healthcare deserts, we can't control where commercial entities build, where they maintain their businesses within reason. They up and move, and our military service members and their family members don't really get that option. They're stationed there or they're deployed to certain locations, and they have to, work in and around what's available to them. And so this really allows us to take all of those resources that we have across the entire ecosystem. Josh mentioned that, one of our biggest challenges is the fact that we are so dispersed across the world, but that's also one of our greatest opportunities. The fact that we have resources spread entirely or across the globe really allows us to leverage that across all time zones going forward with technology. And really, really looking forward to how we bring that to bear. I can speak from personal experience. I can remember the days of not being able to get an appointment so much and having to take the family member to the ER because you can't get into family practice. And so, being able to do things like on demand will be a big deal for a lot of our beneficiaries because it will help ensure that we can utilize our services in the most efficient way possible. So that I think that's an important aspect to it. I think the other part here too is, as Mitch mentioned with our TRICARE partners, there was a lot of great intentions and still are with obviously giving members and their family members, I should say, an opportunity to go out to the healthcare market to be seen where they needed to be. But unfortunately, we are just a reflection of the commercial healthcare market. And so as they've struggled, we've also felt that same struggle. And so using technology helps to bridge a lot of those gaps.
Thank you so much for that, Terry. And to follow on that concept, as we know, there's a new TRICARE contract coming out with the T5 deployments. And within that are new requirements for originating sites. Terry, you had mentioned on demand. And as we think about this, Mitch, can you talk briefly about how the tools that we're bringing forward, scheduled versus on demand versus even automated care, can assist in these transformations?
Thanks, Mary. So I think the core component capabilities that the team is deploying now across the enterprise, the sort of the core telehealth virtual visit component, of which there's two flavors that we've discussed. There's the scheduled virtual visit piece that can be injected into the standard of care, interspersing potentially those brick and mortar visits for patients, enabling them not to have to come into a military treatment facility, is going to create a lot of efficiency, I think, for the care teams, and I think the beneficiary population are going to feel the benefits of that, just being able to have that kind of access. The second flavor of that, as Terry discussed, is the on-demand component. This is something that I think is going to be a game changer for the military health system. We've seen it play out that way within the commercial space. The ability for a beneficiary to, in the moment, say, I want to see a doctor now. My kid's sick in the middle of the night. Or, I don't want to have to get in the car and drive to the MTF and find a parking space and get to the clinic and wait for urgent care, or have to go out into the network. The ability to go to my military health, say I'd like to see a doctor right now, and be able to see a direct care provider, as opposed to having to go out into the network, is going to be a huge benefit for both the beneficiary, because it will help them remain connected and engaged with the system, but also for the care team. It'll give them the ability to more effectively utilize their resources across that global enterprise. And when you bundle that core telehealth or that core virtual visit capability with the other components of the hybrid care model that we're deploying, automation when possible, being able to engage with patients in automated ways, taking the burden off the care team, providing digital behavioral health and self-guided tools to help the beneficiary help themselves in managing things like stress or depression that might be associated with, as Terry mentioned, the constant moves that families might have, or the anxiety that military families might feel when kids are starting a new school or trying to develop new friendships in a market. When you bring all these things together, I think it really creates a unique opportunity for the Defense Health Agency to execute on the vision that General Crossland has articulated in meeting the beneficiaries where they are, anytime, anywhere, and being able to connect them and leverage the direct care resources, again, anytime and anywhere they are. So it's really the perfect match of opportunity, the way the health system is structured, and technology is an enabler to achieve the objective of improving access in a low friction way for those beneficiaries.
All right, thank you so much, Mitch. And as you talk about that, one of the things that you discussed was technology enablers. Josh, you as the engineer that's driving this project, what are your thoughts around this? And can you talk briefly about some of the modernizations that you're doing as we deploy the things that are unique and new? As we all know, in this space, there are cyber requirements, there are hurdles that make things less than eloquent sometimes for the end user experience. Can you please dig into that just a bit more for us and explain what types of advancements, enhancements you're bringing forward that are truly making this a patient-centric experience?
Yeah, on accessibility, that kind of hits close to home. I can remember growing up as a kid in the middle of nowhere here in the U.S. And watching as relatives struggled to get support. And so technology now as an enabler, I can only imagine what my grandpa would have thought of being able to do a virtual session like this, with a healthcare provider, instead of having to wait on a bus to come pick him up and take him 8 hours, to a clinic or a hospital somewhere. That is going to really be an impactful change for the beneficiaries, being able to access that care much faster without the extended waits. And, from a technology perspective, Mitch, you kind of touched on it there. Things have changed, so significantly in the past, 5 years. cybersecurity is always going to be on the forefront of anything we do for our federal customers, and protecting the integrity of the data and the systems and such. So, thank you.
All right, thank you so much for that. And Terry, to kind of dig into that a bit, can you talk a little bit about some of these things in the context of General Crossland's vision and some of the ways that we're really meeting that mission with these tool sets?
Yeah, thank you for that, Mary. So, if for those, as we've mentioned already, digital first is already underway and on track. We've already deployed our wellness app, i.e. Silver Cloud, that Mitch alluded to the first 5 venture sites, and we're already getting great data feedback on that so far. We're seeing scores improve, which is already showing its value, and we're excited to get that out to the enterprise. We've already talked about our virtual visit tool as we look to deploy that across the enterprise, and go from not only scheduled but to on-demand capabilities later this year, initially at the venture sites, at the 5 venture sites, and then on to the enterprise early next year. We've hinted a little bit at automated care. We haven't talked about a little bit entirely about automated care yet, but that is another big capability. One of the things, sometimes you just need the ability to look up things and do it in a very, I'll say, logical way that uses good technology, or not good technology. I'm sorry. Let me back up a moment. Our automated care that allows you the ability to research things that you may be experiencing, that you can get good, reliable, accurate information to help you move along in your healthcare continuum. And sometimes that may mean you need to see someone, but that could be virtual or in person. But that automated care capability, I sometimes refer to it as WebMD on steroids, but it's really much more than that, because we have a lot of things that go with pre and post-op type care, chronic conditions. And really, for a lot of that, we used to require people to come into every facility all the time. It was kind of the norm. And COVID, as Josh mentioned earlier, was a huge forcing function in changing how we did business. The other part that I'll talk about too is, we talked about technology, but one of the other key things is, not only is the technology of what we've done in healthcare changed dramatically. I've seen that firsthand, being a healthcare technology major myself for the last 30 years, but just the technology of what's available to our people, our patients. We can do so much more with a smartphone today. I jokingly tell my kids, and when we talk about the first cell phones, for those of us that remember that, but I jokingly tell my kids they have more power in their hands today than what I had in many cases in my first computer. And I would say arguably probably in a computer I had a decade ago. I mean, it is amazing at the amount of technology and how advanced it's become, and the infrastructure that goes with that across the U.S. And so we're just leveraging a lot of that. And being able to do that really, really just allows us to change how we look at how we deliver healthcare to our patients. It's no longer about a brick and mortar facility. It's really about focusing on where the patient is, and what their needs are at the right time. And so that technology really allows us to do that. The other thing that I'll kind of mention, and I won't mention company names, but as we talk about automated care, or what people will know as virtual companion, think of when you're online and you just have a question with your bank, or some of these other companies that are out there, and being able to just type in a question and get, really good answers back to guide you down the path of where you need to go. And that being in a very responsible way is a huge multiplier in how we deliver healthcare. Sometimes some people will refer to it as asynchronous communication and asynchronous care. They are two very different things. And I'll let Mitch maybe weigh in on some of that. But it's an important multiplier to what we can do in delivering healthcare and delivering good healthcare advice to our patients. And the last thing I'll add, we talk about the future, and as we were talking a little bit amongst ourselves, I was in Alaska in the year 2000, as I jokingly say, and actually the last century in 1999. We deployed healthcare telemedicine systems out to 250 villages. That was almost 25 years ago. we look at what we have available to today, to us today, and the technology is going to allow us to do so much more. We have all sorts of healthcare fitness apps. We have things like Apple Health as an example. We have things that we wear on our wrist that can monitor our heart rate. There is the possibility to do so much more with the information of what we can gather from our patients, whether it be the devices they wear, devices they may use at home, and or logging some of that information as part of their healthcare continuum of just some of the things that they do on a day-to-day basis, which doctors, in all fairness to them and the providers, we don't want to overload them with data, but there's with our ability with our new EHR, there's so much more analyzation that can be done with that system just by feeding the data into that.
Thank you so much for that, Terry. And thinking about this concept of automated care, Mitch, can you kind of walk us through an example of how these tools can assist in reducing provider burnout?
You bet. Thanks, Mary. Thanks for the question. So the Care Companion or automated care capability that Terry was alluding to is really designed to be kind of the tip of the spear, if you will. When we can automate when possible and only escalate when necessary, we're going to enable the care teams to more effectively do the jobs they need to do with patients, either face-to-face in a clinic or conducting virtual visits. And a great example of that, and I think Terry alluded to this as well, is things like chronic disease management. So there's a number of different programs that we're going to be deploying under automated care programs, care companion programs that we'll be deploying under the My Military Health umbrella, 21 in total. The first 4 programs that we're going to be deploying are centered on chronic disease and wellness. So hypertension, diabetes, maternal health, and then an overall health and wellness capability program. Individuals will be enrolled in those programs. So if you're diagnosed with hypertension or you're diagnosed with diabetes, you'll be enrolled in those programs. And the intent is to be able to engage with these populations in automated ways to, one, create a little bit more visibility to their care plan and help them be more compliant with instructions from their care teams in managing their chronic disease on a daily basis. These automated programs are designed to use things like self-determination theory to empower patients to be active participants in the delivery of their health care, maybe checking in with them on a weekly basis or a bi-weekly basis, maybe soliciting input from them about blood pressure values or blood glucose values or general sense of well-being. And then based on those responses from patients, escalate them if necessary to the next best action. That might be pointing them to some education. That might be getting them into a virtual visit workflow. That might be sending them to a workflow that gets them into the clinic because they do need to be seen in a physical space. By doing these things, we believe that we're going to take a lot of the burden off the care teams. We'll no longer need to have care managers picking up the phone and trying to chase down patients. Post-discharge is another great example. Post-discharge programs will check in with patients once they leave the hospital to ensure they're being compliant with their post-discharge instructions. And if things happen to be falling sort of outside the norm of the care plan, of that pathway, we can, in automated ways, escalate them to the next best action, which might be talking to a nurse or talking to a member of the care team if they have a question, for example, about discharge instructions. So that's an example of how automated care companion, I think, is going to fit in the broader equation of transforming how the military health system is delivering care to become a digital-first healthcare delivery network, and in so doing, take some of the burden off the care team.
All right, thank you so much for that. And as we all know, I'm trying to keep this to 30 minutes. So we'll have one last question. We'll do a round of last alibis, and then I'll wrap us up for the day. So Terry, I will direct this to you. As we've gone through this discussion today, a thread has kind of emerged about the difference between digital health and virtual health, and how digital health or digital care is much broader than your traditional understanding of virtual health. So with this concept in mind, can you talk with us briefly about some of the tools and technologies and processes that we are applying within Digital First that can be leveraged across the broader ecosystem of the DHMSM program?
Yeah, and that's a great question. I'll start with sort of the digital front door initiative. It's not necessarily, it may be new to us in the MHS, fairly new, but it's not new in the commercial sector. And the whole concept of going to using reference of what I'll say technology, i.e. digital, is leveraging that space, right? And so, virtual health is obviously a concept that is very, sorry, let me back up for a moment. Virtual health itself is not necessarily new, right? We've been doing telemedicine in one way, shape, or form. You could argue in some ways it's been more phone calls, not always video. Obviously, video gives us a much better experience with our patients. And as a patient, gives you a much better experience with your care team when you can do video, not just over a phone call. Because we've done teleconsults in the sort of virtual space for quite a few years. But particularly with the Digital Front Door Plus initiative, it's taking really all of those technologies that are out there and creating a single entry point, if you will. And when I say that, you can look at, this is one big tool that we're doing here. There are other tools that fall into that process. All the things that go with your EHR, records requests, refill prescript or pharmacy refill prescriptions. You want to see lab results. You want to see your images. There's a lot of that in using that digital technology, if you will, using that as far as your digital front door. And making things very seamless and transparent to the patients. And so really it's just changing that entire delivery model, catering, if you will, to the patient and also to the provider too, right? It's making their job much easier. And I don't want to dismiss or discount that because they obviously have experienced a lot of burnout, particularly with COVID. And so we're trying to make their jobs easier in addition to they get a lot of satisfaction from that when they can provide the best service possible to their patients.
Thank you so much for that, Terry. And over to you, Josh. I know we've had many conversations about this. What are your thoughts about this concept of digital health versus virtual health?
Yeah, Terry said something about the experience of both the provider and the beneficiary. From a technology perspective, providing a single pane of glass, seems to provide an improvement in the user experience. It keeps the individuals both on the care team side as well as the beneficiary from having to search through multiple entry points or screens of data. And so while on the technology side, it certainly presents challenges for integration of the various tools. We are laser focused on improving that user experience, which in turn is going to drive adoption and building up trust between the care teams and the beneficiaries. So.
Thank you so much for that, Josh. I really like you pulling the thread a bit back on not only the reattraction, but providing the tools and technology and the level of care to our service members and their families at the level that they really deserve. So with that, Mitch, over to you. Last but not least, do you have any additional thoughts on this concept of virtual health versus digital health that you'd like to share with us today?
Yeah, I guess the only thing I might add to what's already been said is that individuals, beneficiaries, patients are going to consume varying quantities of these capabilities at any one time. We think of it through the lens of more of a hybrid care model. A hybrid care model that sort of blends in-person, automated, self-guided, and virtual sort of all into one set of capabilities that empower the beneficiary or the patient to sort of decide what is the best way in which they need to interact with their healthcare system in that moment. Giving the care teams as well the tools that they need to guide patients down their care pathways to be more effective and efficient in driving the best outcomes. The military health system struggles with the same challenges that many of the commercial healthcare systems around the country struggle with: hospital readmission rates, chronic disease management, the move toward value-based care. Technology doesn't necessarily solve all those things. It becomes an enabler. Virtual care becomes an enabler to help move organizations in those directions. And I think we're privileged as a team to be able to support the military health system on this journey using tools that have been proven in the marketplace.
All right, thank you for that, Mitch. And to keep us on time, I'd like to do one last quick round of alibis. Josh, I'll start with you. Mitch will go to you, and then Terry will let you wrap it up.
Thank you, Mary. I appreciate the opportunity here to deliver these technologies and solutions. We are continuing to focus this year on delivery of these capabilities to an initial set of locations. We are learning extensively about how we can further optimize the solutions before they roll out to the entire enterprise. So the team is looking forward to continued success in the rest of this year and into next year. So thank you.
Thank you, Josh. Over to you, Mitch.
Thanks, Mary. And Terry, thank you. And Josh, Mary, thank you for for the partnership and for the opportunity to help support the Defense Health Agency and the military health system in this journey. The one thing I do want to say that we haven't really touched on yet is the remarkable speed and velocity with which we have been executing over the last year. And I think it's really a testament to the fact that it is possible to take commercially available solutions and deliver them for the military health system in a way that meets all the cybersecurity requirements and the unique requirements of the military health system as a global healthcare delivery system. And I think it speaks to the power of the partnership, the role of the integrator, and the collaboration with the Defense Health Agency and the program office to execute at speeds that I think very few of us have ever seen the government operate at to effectively deploy a solution in under a year, as broadly and as comprehensively as we have across all the different domains of capability that we're delivering: virtual visits, automated care, digital behavioral health and wellness, not to mention the transformation that's needing to happen from a change management perspective at the deck plate or within the military treatment facilities to internalize this and effectively operationalize it across the enterprise. So Terry, I want to thank you and the Defense Health Agency and the DHMSM team, and Josh and Mary, I want to thank you and the Leidos Partnership for Defense Health for the opportunity to participate in this journey. I think we're going to see great outcomes in the months ahead, and I'll turn it back to you, Mary. Thank you.
All right, thank you very much for that, Mitch. And over to you, Terry.
Yeah, thank you first of all to Josh and Mitch and Mary and the greater team. I mean, the team is significant and the amount of collaboration that we have on a daily, weekly, monthly basis. I can't speak to that enough. And as Mitch alluded to, the pace at which we have gone has been certainly at times, I'll say a series of sprints within a marathon. So, which is always interesting when I reference it that way, because you're thinking, how do I ever make it to the end? And so it's been a great experience. We've gotten great feedback. Certainly we have challenges. There's no doubt about that. We'll continue to have challenges, but just the fact that everyone's committed to doing this and doing it at the right way is really just a testament to the entire team and everyone's dedication to this initiative, but also just to serving our population. And so I can't say thank you enough to everyone involved, both on Amwell, the Leidos side, or the Leidos Partnership, I should say, the DHA team, and of course our own internal DHMSM team. So it has been a phenomenal experience. I really look forward to where we're going to take this in the next several years and beyond, because we are shaping what the MHS is for the next several generations. And so this is really a major turning point in how the MHS will conduct business going forward.
All right, thank you so much for that, Terry. This has been an incredible session, and I've really enjoyed listening to what each of you have to say as we make this transition into a true value-based care model. And I must say that it is a true honor to be a part of this transformation, and I truly appreciate the opportunity to be a part of it. For those of us that are dialed in, There will be an additional series that are coming forward. We'll dig a little bit deeper into what the digital front door is. We'll dig into what we're doing at the originating sites, and then we will wrap up at a virtual health symposium coming later in the year. Thank you, and have a good day.
This concludes today's episode of the Fed to Fed Podcast MHS Digital Front Door Series in collaboration with the Leidos Partnership for Defense Health. If you enjoyed this episode, please don't forget to visit the MHS Digital Front Door landing page at govtechconnects.com for the latest in MHS thought leadership. Thank you so much for joining us.